All right, hello everyone. My name is Shelby Reiter. I'm a second-year general surgery resident at Swedish Medical Center in Seattle, Washington. I'll be presenting outcomes following early versus delayed cholecystectomy performed for acute cholangitis. We have no disclosures. Laparoscopic cholecystectomy is recommended following an episode of gallstone-related acute cholangitis. However, the optimal timing of cholecystectomy is unclear. Early cholecystectomy following cholangitis does not appear to be the norm in the current day, with only 28 to 30% or 37% of patients in the literature receiving early cholecystectomy after cholangitis. The 2018 Tokyo guidelines provide a useful framework for diagnosis, classification of severity, and treatment algorithms for cholangitis. They also recommend cholecystectomy, but do not include an optimal time frame. Benefits of delayed cholecystectomy after cholangitis include potentially allowing for a cool-down period during which inflammation and infection can resolve. Inflammation has been shown to be an independent risk factor for bile duct injury during cholecystectomy. Furthermore, delaying surgery and rather discharging patients and having them return for elective cholecystectomy has been shown to be more cost-effective. It also allows time for optimization of other medical problems prior to surgery. On the other hand, benefits of early cholecystectomy after cholangitis include a decreased risk of recurrent biliary events prior to surgery. Oops. The aim of our study was to determine if cholecystectomy during index admission for cholangitis was safe. To answer this question, we performed a retrospective chart review of all cholecystectomies performed for cholangitis at our institution from 2008 to 2015. To be included in this study, patients had to meet the Tokyo guideline criteria for cholangitis, which can be seen on the side of this slide. All patients who were included were also assigned a Tokyo severity grade 1 through 3, or mild, moderate, and severe. We then compared patients who underwent cholecystectomy during their index admission for cholangitis to those who were discharged and returned for delayed cholecystectomy. We also compared patients based on their Tokyo severity grade. The main outcomes we looked at were operative times, rates of conversion to open cholecystectomy, and complication rates. We found a total of 151 patients. 93 of these patients underwent cholecystectomy during their index admission for cholangitis, while the other 58 were discharged and returned for delayed cholecystectomy. The mean time to surgery in the index admission group was 1.8 days, whereas for the delayed cholecystectomy group, it was about 6 weeks or 42 days. When comparing patient baseline characteristics between these two groups, we found that patients in the delayed cholecystectomy group were more likely to be male and were significantly older. They were also more likely to have comorbidities such as coronary artery disease, hypertension, COPD, and a history of stroke. When comparing their admission laboratory values, we found no significant differences between these two groups. When looking at treatment characteristics, we found that patients who required ICU-level care were significantly more likely to have a delayed cholecystectomy. We found that patients in the index admission cholecystectomy group were less likely to have a preoperative ERCP, but were significantly more likely to require a postoperative ERCP. When comparing length of operation and rate of conversion to open cholecystectomy between these two groups, we did not find a significant difference. Of note, 2 patients in the delayed cholecystectomy group developed recurrent cholangitis while awaiting surgery. When looking at complication rates, we found that the delayed cholecystectomy group had higher rates of intraoperative and postoperative complications. However, only the difference in postoperative complications reached statistical significance. When looking at the overall complication rate, 29% of patients in the delayed cholecystectomy group had a complication, being either intraoperative, postoperative, or both, while only 16% of patients in the index admission cholecystectomy group had a complication. However, again, this failed to reach statistical significance. We then compared patients based on their Tokyo severity grade, with Tokyo grade 1 being mild, 2 being moderate, and 3 being severe. The rate of cholecystectomy during index admission was similar for all 3 severity grades. Furthermore, the length of operation, rate of conversion to open cholecystectomy, and complication rates were similar for all 3 groups. So, to summarize some of the main points we found in our study, operative times, rates of conversion to open cholecystectomy, and complication rates were similar across all Tokyo severity grades. We also found that operative times and rates of conversion to open cholecystectomy were similar for patients who underwent cholecystectomy during index admission when compared to those who had delayed cholecystectomy. However, we did find lower complication rates in the early surgery group. When comparing these findings to Lee et al.'s 2010 retrospective review of patients with cholangitis, in which they compared patients who had surgery within 6 weeks compared to those who had surgery greater than 6 weeks after their cholangitis, they also found similar operative times and rates of conversion to open cholecystectomy for both groups, but a lower complication rate in the early surgery group. In conclusion, based on these findings, early cholecystectomy during index admission for cholangitis is safe to perform. It has similar operative times, similar rates of conversion to open cholecystectomy, and lower complication rates when compared to delayed cholecystectomy. Based on these findings, we would recommend cholecystectomy during index admission for cholangitis. Thank you. Thank you.